Excellent. Okay, so on this very exciting slide, to be honest, if you couldn't see it, it doesn't really matter. How actually the important thing about it is the link at the bottom, which is actually to the guidelines. Now, these guidelines were revision of ones that had existed since 2007, and they outline the investigations we do to try and help you decide on the context of a child undergoing safeguarding concerns. And the aim of our imaging is to help identify any occult injury that you can't see clinically, to clearly identify injuries that you can identify clinically. So, you know, if the child has come in with an obvious fracture, to help date injuries if at all possible, and really to sort of be part of the overall group in trying to decide whether a child is at risk or not. And we want to use obviously the least radiation we possibly can and the least invasive technique we possibly can. So these guidelines, and actually it's been in place for a long time, is the recommendation firstly is for children to get a skeletal survey. Now, this only applies to children under the age of 2. Over the age of 2, the type of injuries they get are different, and the skeletal survey is really not so helpful. But if they're under 2, they should have a skeletal survey. If they're under 1, they should also have a CT head. And if you've got any neuro concerns, or if they actually present obviously with head trauma or serious neurological concerns, then they should also get a CT head, even if they're over 2. For the older children, come and talk to us or your local radiologist and make a decision on a case-by-case basis as to what imaging is going to be the most appropriate. So the reason that these guidelines have actually been very helpful to us are that they've included quite a lot of extra views, which from the parents' point of view may be alarming, but from our perspective really helps us in seeing the abnormalities that we're looking for. And I would say that the purpose of the skeletal survey is to identify 3 main areas of abnormality. So one are the metaphyseal fractures, secondly, rib fractures, and thirdly, looking for head injury. And these current guidelines help us in really determining all those, and I will go into that in a bit more detail in a moment. The additional views are also helpful for dating injuries. The most controversial part of these guidelines, and it's possible you've been involved in looking at this yourself, is if we find a serious injury in the index child, then any child under the age of 2 living in that household should also have a skeletal survey plus or minus a CT head, depending. And I think certainly in our own department, this has probably been the most controversial bit of all the guidelines. And so far, I'm pleased to say that we haven't actually found injuries in other children, but there is actually good evidence out there, particularly looking at twin pregnancies, that the incidence of injury in other children is really quite high, and certainly high enough to justify the risk of the skeletal survey. The other 2 things that have been really helpful from these guidelines from our perspective, and things that you may also have been involved with yourself, are one is the patient information leaflet, and secondly the consent form. Now, I don't know if any of you have been asked to, but certainly when we're doing a skeletal survey, we ask our paediatricians to consent the carer. And as part of this, they're given the information leaflet, and the whole process is explained to them. And this has been absolutely fantastic for us because, as you'll see later in the talk, there are a lot of images taken in this survey, at least 20 x-rays, and it can take well over an hour. And quite often, not unreasonably, the parent would get quite distressed during the examination, and we'd have to stop it and send the child back to the ward. Whereas now, with the consent thing in process, we've not had any patients that we've had to send back only having half completed the survey, because the parents understand what's going to be happening, realise it's going to take a long time. It seems to be much more acceptable to them, and it's made our job a lot easier. So just a little bit of a review here of the key areas. So metaphyseal fractures, we don't know exactly how they occur. Obviously the perpetrators are not going to admit to us how they cause these injuries. One theory is that they may be a twisting sort of injury, like a Chinese burn. Other people feel that it could be part of a shaking episode. So in a young child who's obviously got very limited muscle control, if they're being shaken vigorously and the limbs are sort of flexing and extending in an uncontrolled fashion, that may be enough to cause the trauma. One thing we can say is that we don't see them as part of normal childhood caring. So if we're x-raying children for other reasons, you know, infection, or you see an arm on a bit of a chest x-ray or whatever, we do not see corner fractures as part of normal childhood activity or caring. So if we do identify them, they are very suggestive of NAI. The other metaphyseal abnormalities that you get in things like scurvy, rickets, metaphyseal dysplasias, various other deficiencies don't look like this. So if we see these injuries, it is highly concerning. And the reason the metaphyses get injured in this age group is that if you look at this picture here, the corner of the periosteum is very loosely attached at this point on the metaphysis, and so it can be pulled off, and that's what happens as part of these injuries. And this is an example of an X-ray version of this, the bucket handle injury. So the whole of the edge of the metaphysis has been pulled off as part of this injury, and there's a little corner fracture down here. This is a much more severe injury. Oh, sorry. Fortunately, we don't see it very often, where the edge of the metaphysis is completely pulled off, and this is probably due to hyperextension. So these fractures don't occur in the older child, and that's one of the reasons that we don't recommend a skeletal survey in the over 2s. The metaphyses become more mature by that point, and the periosteum is less fragile. And this is why the focal views are so helpful, because we're really looking specifically for these injuries in this part of the examination. So this X-ray here shows the leg of a young child, and there is a corner fracture that we can identify on this image here in this lateral view. When we do the zoomed in view, actually there's also a very thick double border. So this is a thick periosteal reaction around the distal tibia here. Now, you could argue that obviously with PACS, we can actually zoom up our pictures to however big we want, which is true, but we lose a lot of resolution. And while I think this injury would be visible even on this view, actually there are much more subtle things that are difficult to see without a focal view, and particularly when you haven't got the beam angled in the correct place. So if your beam is angled up here, you may get funny views down here, and that's what these views are hopefully going to prevent. The next area that we're looking at, so we've done metaphyseal fractures are one big focus of the skeletal survey. The next big focus is rib fractures. Now, rib fractures in children are actually very uncommon. The ribs are extremely pliable, and you can almost get the sternum down to the spine without causing a rib fracture. So big studies that have looked at CPR, for example, and rib fractures, looking at thousands of children, have found in some studies none. In one study of 31,000 children, not a single one got a rib fracture as a result of CPR, if they have a normal skeleton. So if we see rib fractures in the absence of a significant trauma, then it's very suspicious for NAI. The problem is they can be very difficult to see, particularly before they get a callus on them. And as a result of that, we do 3 views in the skeletal survey, specifically looking for rib fractures. So we do the standard AP chest. This child will be supine for these, and you can see with the arrow pointing here, but this is suspicious for a fracture. That we can see irregularity of the cortex here and a periosteal reaction. When we look at this view, which is the right oblique view, so we can see these ribs on the right hand side really beautifully, there's now a suspicion of this fracture here. Now, it's possible it's there, but I think this is quite subtle, and this is a lot more convincing. When we do the abdominal view, we also get to see the bottom end of the ribs, and then we can be, yeah, there is really likely to be a fracture at this point. So we do the left oblique AP and right oblique views, and also see the ribs on the abdominal view. And it's important to look at all these to try and successfully diagnose all the rib fractures. Here's another example of this poor child who's had multiple rib fractures. So this is a nice left oblique view, and you can see there's an acute-ish fracture here with a fracture line. There's some callus around these fractures, more callus around here on the anterior ends of the ribs, and some almost healed rib fractures here. So this poor child has probably had 3 separate episodes of significant chest trauma to create these different ages of rib fracture. Okay, so any questions? Anyone want to ask anything at this point? Okay, so I'll just carry on then for the moment. The third area, so we've had hips, metaphyseal fractures, and the third area is cranial imaging. Now, obviously, some of your children are going to present actually with a devastating head injury as their initial presenting point, but there are a significant number of children who will have abnormal cranial imaging picked up as part of the skeletal survey, and it's actually clinically unsuspected. The skull X-ray is done as part of the skeletal survey, but the other investigation is the non-contrast CT head. Now, this should be a volume scan so that we can get reconstruction in different planes and look at a 3D image. It's without contrast because blood appears very white on a CT scan, acute blood. And if you've got contrast in there that also looks white, it can really confuse things if you've got both things present. So the CT head should be done without contrast. If it's abnormal, they need to go and have an MRI at 2 to 5 days, or if the child remains neurologically abnormal with a normal CT, they should still have an MRI at 2 to 5 days and accompany that with the MR of the spine at the same time. And that's because a lot of these injuries are thought to be due to shaking, and obviously shaking, the same forces during the shaking episode can also cause significant spinal flexion injuries. So here's an example of why the 3D imaging can be useful. So this child presented with swelling over this side of the head. There is what we think is a fracture here in the left parietal bone. But when you come to look at the image on the reconstructed 3D picture, we can really nicely see this fracture going here across the left parietal bone. So in this case, we were quite sure that there was a fracture, but sometimes it can be difficult to differentiate between a fracture and a suture, and the volume ability really helps us to make that decision. This is why head injuries can be so important to detect. This child actually came in with a devastating head injury. This image at the top was the initial one. The ventricles are still patent, but if looking at the cerebral hemispheres, they are very low density. We've lost the usual grey-white matter differentiation, and we can't see the sulci. So this is beginning to become edematous. 2 days later, the brain really looks absolutely terrible. The cerebral hemispheres have become very low density, extremely edematous. The basal ganglia and the cerebellum remain bright white, and that's why sometimes this is called the white cerebellar sign. NAI is not the only cause. Basically, any cause of severe hypoxia will end up with this, can end up with this appearance. So it could be birth trauma, drowning, terrible blood loss, but in this context, this was after an episode of shaking. This child actually survived, but this was the brain at the age of 3, and it's completely shrunk away. It's like a little tiny shriveled walnut in the middle of this big sort of sea of extraaxial CSF. These brains are very, well, the head is very prone to spontaneous bleeds. The vessels are all kind of stretched through the CSF. Now this child's obviously not in the care of its original carers anymore. However, this still needs to be investigated because this is acute blood. This in fact was thought to be just an unfortunate incidental finding rather than any further trauma. But clearly this child is going to be very disabled.
Joanna, one of the audience is just asking, what
Yes.
is the procedure of reporting skeletal surveys that are suggestive of NAI? Is it 2 independent reporters, and when is an external opinion required?
Okay, yeah, sure. So we in our trust always use 2 reporters. Obviously, we are both working in the same trust, but we report. One of us will do a report, and then we will get somebody else to also do their report independently, and then we put the 2 things together. The business and external report, we will sometimes send, we had a case quite recently actually, and we were concerned that there might be an underlying skeletal dysplasia as part of the abnormality. So we will sometimes choose to get an external report for our own benefit. From the point of view, now I have to say I'm not experienced. I don't actually go to court about these cases as an expert. There are a few experts in the country who take on lots and lots of this work, but that is very much done at the kind of court's decision. So they will, because when I started in this actually, you'd end up going to court and there'd be a lot of arguing with so-called experts who were really, really out on the fringe of what was considered to be acceptable evidence. And some cases really were completely destroyed by somebody whose opinion really wasn't particularly respected within the medical profession. So they've tried to it's not that they want everyone to agree, but they want experts who really are experts, and not people who've just come out of somewhere and are claiming that some very strange, food nutritional deficiency that you can't actually identify in any way is, say, responsible for these fractures. So to try and sort of get it on a more scientific basis, there are experts who will be called upon by the courts. And sometimes, we've not actually, we get on really well with our paediatricians, so we've not had anybody them saying, oh, actually, we don't believe you, we want another opinion, but that's possible. And also we do sometimes get asked by maybe a DGH who don't quite see so many cases. Sometimes they'll send it to us to ask for our opinion as well. Is that helpful?
That's great, thank you.
Okay, no problem. So this was a 6-month-old boy who'd been left with a babysitter by his parents, and when they came back he was crying and distressed and not moving his arm, so they brought him to A&E, and there was a fracture in his ulna. So he had a skeletal survey, which was fortunately otherwise normal. There's no healing on this fracture. There's no sign to think this was a delayed presentation. So it looks like an acute injury. He had a CT head as part of his examination, even though there were no neuro concerns. And this does show a bleed. He's got this bright white line along here in the extraaxial CSF space. And this is consistent with an acute bleed, an acute injury. So this is an example of picking up an unsuspected neuro abnormality. It's helpful because both these injuries, although we can't be absolutely precise, both these injuries are acute. So it's like to be one episode. And then if you're trying to decide between was this parental, was it a babysitter who's doing it, this kind of evidence is helpful. Not always conclusive, but it is helpful when you're trying to build a picture in a court situation. So the process in our hospital is that usually it comes from you guys to us. Occasionally we'll see something and think, oh God, this looks really concerning, and contact you, but normally it's the other way around. We have, as I say, good relationship with our paediatricians, particularly the ones that are dealing with child safety. We will decide between us that it needs to be done. We then ask you guys to get consent, and there's just a few points here on things that you might want to say in your consenting process. This is really well described in the document from the college, so if you want to download that, and there's copies of the consent form, there's copies of patient information leaflets that you can use. And so, as I said before, there's at least 20 x-rays going to be taken, so it can take well over an hour for it to be done. The radiation dose, obviously parents might be anxious about that. It's not great. It's not big because it's only peripheral x-rays. It's about a month or two of natural radiation. CT head is obviously more, and that's about 18 months of radiation. But you can reassure them that the radiographers do everything they can to keep the dose as low as possible. It's helpful if you can also talk about the need for follow-up imaging and possibly for MRI if you think that's going to be necessary. Because what we found is the more information that the parental carer has, the less stressful the whole procedure is when they come down to the department and have it done. We only do these during the week because we need 2 radiographers. The child has to come down with a qualified paediatric nurse. They can't come down with a healthcare assistant or a student of any sort. No students can be in the room, no student radiographers or anything like that. The parent can come if they're not considered to be a risk to the child. And sometimes we'll get a play therapist with an older child. They can be really helpful as well. This is a list of all the views that we take, just for your information really, but you can see there's quite a lot, and it can be up to 28 views depending on the size of the child. The follow-up films should be done at 11 to 14 days. So in these we will look at any x-ray, any area that is abnormal on the first one, plus some standards, which are both the limbs and focused views. We don't repeat the CT head at all, and we use the follow-up views really to help confirm an injury. Sometimes we won't be sure if it's a normal variant or if it's something that is concerning or not. It can help with dating, and it can help pick up injuries that were not visible on the first survey. So this child came in, had the 2 views of the elbow, which we thought were probably normal. There is, which may not project very well, there's possibly a little lucent line here, but we weren't really at all convinced that that was a fracture. However, when they come back, that lucent line is now much more easily seen, and there's a definite periosteal reaction here, seen here and also seen down here. So we know this is definitely a fracture. So that was a really helpful one for us. This is another example. This was a 6-week-old girl who came in with a history of not moving her leg, and there is a bucket handle fracture at the distal end of this tibia. When she came back 10 days later, we can see that actually the injury wasn't just to the ankle, but it affected the whole of the tibia, because there's a very thick, obvious periosteal reaction along here and seen here. So this was a more significant, I mean, it's not probably an additional injury, but it just shows that the original injury was more severe than initially seemed. Now, obviously, the classic presentation that we learn because of our radiology point of view, but is also probably something that you guys learn too, is that, you know, children presenting with fractures of different ages, fractures without adequate history, you know, very much fracture based. However, there are other presentations that everyone needs to be aware of. This particular child came in with an acute abdomen, and on this abdominal X-ray, there are loops of dilated bowel seen here. However, anybody who's really observant might notice this femur down here, and there is actually a healing fracture of this femur as well. So this hadn't presented. This would have been clinically obvious to the parent. You know, this leg would have been very painful if you subsequently examined the leg and saw that it was swollen. But the original presentation was with an acute abdomen. This is quite a lot. This is from a long time ago, this case actually, and at that now we probably do a CT, but at that time they had a contrast study, and that showed this is loops of small bowel filling here, and at this point there's a filling defect, and this is a hematoma in the small bowel, and this is thought to be the result of severe compression to the abdomen, so punching or kicking type injury, and small bowel hematomas are unfortunately a feature of that particular type of trauma. This child came in with what was thought to be anaphylaxis. He was 3 months old. He came with a history of acute swelling of his face and neck, and the A&E doctors got into their resuscitation mode, were trying to get in a line into his scalp, and realised that he actually had really, really extensive subcutaneous emphysema. And when we look at the chest X-ray, there is air up in the soft tissues up here, air tracking all the way up his mediastinum. There's a pneumothorax. And he has these old rib fractures, this callus formation here. Now, those rib fractures can't be responsible for this injury because this is acute. And when we did further reviews, he was found to have acute rib fractures as well. And then there's a few other ways they can present. So this child came in with abdominal pain again, and this was a perforation, again from what was thought to be a compression injury to the abdomen, causing perforation of bowel. It's usually duodenum that perforates in that setting. And this is another one where a child came in actually septic, and this was initially thought to be an artifact, but subsequently found to actually be within the peritoneal cavity. And it was removed, and then another one appeared, and several more. And the mother had been actually putting these into the child's abdominal cavity. And I think this is the last case coming up on this section. So this was another slightly older child. This is a 3-year-old. He came in again actually with an acute abdomen, but as part of that had a chest X-ray to look for free air, which there wasn't, fortunately, but he had this in his mediastinum. And as we saw in that previous case with the head and neck swelling and mediastinal air, it was associated with rib fractures. And I would urge you, if you see mediastinal air in a child without any obvious cause, I mean, sometimes they might have had instrumentation, they may have had severe asthma, but if you see it with no cause, please think about inflicted injury, because it is associated with rib fractures that may not be visible to you. Even just a very severe chest compression can cause it, even without a fracture. And also sometimes the parent can shove, or carer can shove some sort of sharp instrument into the oropharynx, and you can get air in the mediastinum by that way. So I always urge our registrars to have non-accidental injury high on their list of possible causes of mediastinal air. In fact, there is a rib fracture here, we can see, and actually he went on to, because he'd had the abdominal presentation, went on to have a CT. There's a rib fracture here, that's his mediastinal air, and then this is his upper abdomen, and there is a fracture through the pancreas. And if you have a big force coming in through this direction, it's going to push everything onto the spine, and so that's why the duodenum is the likely place to be perforated in this setting, and the pancreas is also particularly vulnerable to that kind of injury where everything's being forced against the spine. And finally, there's just one more example of an older child. So, as I said, we're not looking for metaphyseal fractures and things in the older children, which is why we don't do the skeletal surveys. But sometimes we will do them to look at individual bones. Sometimes we'll just maybe X-ray each of the long bones just to make sure there's no previous fracture that never presented. This child was 13 and had severe cerebral palsy with dreadful contractures, and he presented with acute abdomen, but the ICU doctors were very concerned about his general state of nutrition. You can see he's incredibly thin, and we discussed about what options there were for imaging. Now, this poor child was seemed to be in very severe pain most of the time, and any movement of any part of the body seemed to make this worse. So we wanted something that was as easy to do as possible for the child, and in the end we decided to go for CT. So this child was just brought down to the CT scanner, put onto the CT bed, and had one scanogram view done of the whole body, and we were able to look at all the long bones really apart from his knee in this one image, and exclude any previous fractures. So this was quite a good way of really not interfering with the child too much, and just having them lie in one position and getting a lot of information, although it's not something we recommend in every child. Okay, so that is the end of the NAI section. Has anybody got any more questions before we move on?
Yes, so Harmeet's got a question. She's asking, you mentioned about getting a CT abdomen for the child with acute abdomen. I recently had a time case with a head injury suspicious of NAI with a GCS of 3 requiring intubation and transfer. In this circumstance, would you advocate chest x-ray, CT abdomen, CT spine and head, as I've seen in the RCR guidelines, or would you do CT head, CT spine, chest, abdo, pelvis, so the whole lot?
Okay. Sorry, did it say how old that child was?
It does not say the age notes.
Okay. I'm going to talk a little bit about that kind of major trauma patient in a moment. I think that the child that we had before who ended up having the CT, I mean, I wouldn't normally advocate CT abdomen for acute abdomens on the whole. Normally we would go down the ultrasound, to start with, looking for appendicitis. It depends very much what you're looking for. In the context of suspected NAI, the useful thing about doing a CT abdo-pelvis, in addition to the fact you're going to see, if there's any free air, you might see the site of any leak. You might, we're not going to see that fractured pancreas really probably in any other way. You also get to look at the bones, and you can see we saw those rib fractures. So I think in the context of NAI, it's a different discussion that needs to be had, because we're looking for slightly different pathology. And in your case, if you were thinking that was an NAI case and the child was already intubated and unconscious and had a severe head injury, and you were concerned about the abdomen and they were over 2, then I think maybe go to CT abdo-pelvis. The chest, usually, as you'll see in the trauma talk, I would say chest to chest X-ray. There is a debate about using CT chest to look for rib fractures, and undoubtedly it is more sensitive. But I think the jury is still out on how much more, whether it's sensitive enough to be better than doing AP and 2 obliques on 2 occasions, 14 days apart, whether actually that's enough. And there's other ways that you can use things like MRI as well. And also the other issue with this is we're very confident that when we say that you're not going to get the chest rib fractures visible on chest X-ray in CPR, in various other things. However, how confident are we to say that actually, if you did MRI on children who'd had CPR, how many of them would have bone edema in their ribs? How many of them would have maybe occult fractures on CT as a result of CPR? Which makes it slightly more difficult when you're trying to say, yes, this is more or less likely to be NAI. So I think it's a slightly complicated situation, and I think something like that is obviously fortunately quite uncommon, and the best thing is really to talk to your radiologists and take their advice And if you have real concerns, then I think CT is fine. Yeah.
Brilliant, thank you.
So anything else on the NAI setting?
Can't see any other questions. Harmeet says thank you.
Okay, that's fine. So I'll now go on to the major trauma, and similarly, do put stuff in the chat box, and we can deal with those as we go along as well, and also there'll be hopefully a little bit of time at the end. So St Mary's became a level 1 trauma centre in 2010, which is when the government had decided to roll out trauma centres, and we were one of 4 in London. This was very much done from the adult perspective, and actually I'll just move on to the next slide. So this was the data. TARN are the national network that look at trauma data across the UK, and you can see from this, if you look at this people over the age of 16. So you have about 35,000-40,000 adult trauma patients per year, opposed to a couple of thousand paediatric ones. So you can kind of see why they decided to not even think about paediatrics in some ways. But as I'm sure you share my frustration working in paediatrics, that we're always forgotten about until somebody puts their hand up and go, excuse me, but what about the children? And in the trauma scenario, they have different types of injuries. There's different risks to the radiation. There's all sorts of reasons why they need to be treated differently. But anyway, in the initial setting out of trauma centres, there was no provision or thought about how paediatrics was going to be managed. So for the first few years, certainly at St Mary's, they were managed by people looking after adults. There were no paediatric, unless the paediatric A&E was open, there were no paediatric trauma leads, and there was no paediatric radiology provision out of hours. So it wasn't ideal. This is just showing the kind of how our children get injured. Most of them are in this group, so road accidents and penetrating injuries. And we're not a burns unit, so we really don't get many burns. They go to Chelsea Westminster. Right, going back to this slide. So if we look at the type of injuries that children are getting, most of them are getting isolated head or isolated extremity injuries. Very few have multiple injuries, and very few have chest and abdo injuries. So the idea of scanning them head to toe, which is what happens in the adult trauma setting, is really not a good one. The chances of picking things up are going to be pretty small, and you've got the added risk of unwanted radiation in really much more radiosensitive individuals. Out of the data came also the fact that almost 90% of children are not seen in paediatric trauma centres. Most of them are seen in just general hospitals. And this means that many more of them end up having CT than they do when they're seen in paed setting. So in outside paediatric trauma centres, about 9% were getting a CT from head to toe, compared to 3% in paediatric trauma centres. So our feeling was that children were being over-imaged because they were being treated like adults, and that something needed to change. And we needed to set some guidelines in place to help people who weren't in a major trauma centre give more appropriate guided imaging to any patients who may come in. So in 2013, a group was set up, and I was actually one of the London representatives. So this was from across the UK, involved not just radiologists, but also paediatric emergency medicine doctors, paediatric surgeons, interventional radiologists. So everyone had a kind of interest. And we looked at the evidence in all the various different ways, and then came up with some guidelines that were published in 2014, and you can find them on this link. Hoping that they'd be used as a guide, particularly for people who didn't have access to paediatric A&E or paediatric radiology. And they deal with the guidelines in a body part way, and so I'm going to go through the rest of the talk just in that same way, and we can start with head injuries. So basically, the NICE guidelines have been in place since 2007. There seemed to be absolutely no reason to disagree with them. They seem to be good for purpose, and so we just said, fine, carry on with the NICE guidelines and just do what they say, and that's absolutely fine. The skull X-ray is only used for skeletal surveys in NAI, unless it's a foreign body, and CT, again, without contrast, is the investigation of choice. Here are the NICE guidelines for heads if you want them, but I'm sure you are all familiar with them and they're quite well used. Secondly, cervical spine. Now, the problem with the cervical spine is that it involves irradiating the thyroid, and the thyroid is extremely radiosensitive. When we look at the radiation damage data that came out of Hiroshima, there were many, many thousands of extra thyroid cancers in the years after the nuclear bomb, and children's thyroids are particularly sensitive, so we don't want to be irradiating them unless we have to. And the slight problem with the NICE guidelines is that which are here, is that if you read it superficially, it seems like any child that's intubated should go on and have a CT neck. And a bit like your previous question there, is like, oh, but you know, they've had a head injury and they're intubated. Should we just do the whole thing? Well, our answer to that really is no. You need to have a clinical suspicion of cervical spine injury before you set off on this pathway. Once you have that suspicion, this pathway is fine, but I would just urge you to not go into it too early. And if there is no clinical suspicion and the child has just fallen over at school and has hit their head, they don't necessarily need to have a CT cervical spine. So this should be after some clinical assessment and review of the actual clinical details and neurological status, rather than just a kind of reaction and everyone getting it automatically. And most spinal imaging can be done with plain films. Obviously, there's going to be some cases where the child is acutely ill and you haven't got time to fiddle about, in which case, just do what imaging you think best at the time. However, in general, we would suggest a case-by-case discussion with the radiologists. Your clinical assessment is really, really important. And if you have really awful clinical concerns about injury, MRI is actually the best test, but we're very lucky here, we can get that quite easily. Lots of places can't, and therefore targeted CT is absolutely fine. You must never feel guilty about irradiating a child, when the risk of picking up, not picking up an injury is so devastating. If you miss a spinal injury, that is fine to do it, but it should just be thought about rather than just done as a thing before the child even comes through the door. And X-rays are normally enough. And remember that if you've already done a CT of the abdomen and pelvis, the lumbar spine is on there. So you can always look at that as well before thinking about any further imaging. Now moving on to the chest. So chest injury in children is quite different to adults as well, especially the young children, again, because the ribs are so pliable. So because they don't break, they don't absorb the forces as well. So children are actually more likely to get lung contusion and pneumothorax than adults. They can also get a devastating asphyxia due to just very high pressures within the chest that can't be relieved by fracture, and so you end up with episodes episodes of hypotension. And actually, quite a lot of children die at the scene from thoracic injury. So by the time they get to A&E, they're in a good place to start with. And in the situation of blunt injury, a chest X-ray may be enough, but they're not the same as adults and shouldn't be just CT scanned willy-nilly without thinking about it. So this is all about blunt trauma. So chest X-ray is the first investigation, and that's often done as part of the primary survey in the trauma centre. And if it's normal and the patient's conscious and stable, often a CT will add nothing and doesn't need to be done. So this child had actually had a CT elsewhere. You can see contrast in his collecting systems. This child came in having been hit by a car. The chest medial dynamic spine, the chest is completely clear. There's no rib fractures. We're not concerned about this chest X-ray. He did have a CT, and at the top slice of the CT, you obviously include the lungs, and you should always look at them if they're included. And there is some contusion. There is a little bit of a pneumothorax. So it's not completely normal, but neither of these things are going to affect his management in any way. So there's no reason to scan the rest of his chest when we've had a reassuring chest X-ray like this. He's had blunt trauma and he's otherwise completely fine. This child had an abnormal chest X-ray. You can see he's intubated. He's got a lot of opacification in both lungs, particularly on the left. Did have a CT because this was abnormal. Showed lots of contusion. Hasn't changed his management in any way, but it's hard to argue against doing it when you have an abnormal chest X-ray like that. This child, on the other hand, is stabbing. So this is a penetrating injury, and this needs to go down a completely different pathway. Stabbings, so if he's been stabbed in the chest, a normal chest X-ray is not enough to exclude serious injury. So in these patients, the chest X-ray is useful as a primary thing. It's useful to see if you've got anything really acute that you need to sort out before he even gets into the CT scanner, like a massive pneumothorax or a big bit of metal sticking out of his chest. But his heart is big, so this is not normal. and he's been stabbed. So he definitely needs to have a CT scan, and he has one. And this shows a pericardial effusion and a pleural effusion as well. So fortunately, by this point, he had no active bleeding, and he went on to make a good recovery. But you cannot tell either of those things from the chest X-ray, and it's imperative that these patients do get imaged actively if you've got any concerns about them. So just moving on to the abdomen. And the first thing I'd like to say about abdomen imaging is fast scans, which are part of the adult trauma protocol, are not indicated in children. The reason for doing a fast scan is to decide which patients need surgery. And if you see fluid in a child when you do a fast scan, fluid in the abdomen, they may not need surgery. Almost all children with solid organ, abdominal organ injury don't need to go to theatre. Almost all of them are treated conservatively. So if you see fluid, it doesn't mean they're going to theatre. Also, if you don't see fluid, it doesn't mean so they're not bleeding. Children, because they have such stretchy soft tissues, can have huge perinephric hematoma, for example, because of bleeding into the kidney, and yet nothing in the abdomen. So a fast scan is not indicated, and if you want to do anything, it should be a CT scan. This is an example of why that is, why ultrasound, I'm afraid, much as I love ultrasound, is not good enough in this setting. So this child came in and had this injury to the liver. There's a contusion in the right lobe of the liver. The portal veins are actually nicely patent on here. There is a pleural effusion, there is collapse of the lung, and there's some soft tissue swelling. This ultrasound was done about 12 hours later, so pretty much at the same time. We can see the veins beautifully, we can see the pleural effusion beautifully, we can see the consolidated lung beautifully, and even the soft tissue swelling in the chest wall beautifully, but we can't see the liver contusion. We see a tiny bit of subcapsular fluid here, and a little bit maybe of irregular echogenicity, but it's nothing like as clear as it is here. So unfortunately, if you've had severe abdominal trauma, we have to do a CT. Ultrasound is not enough. But it does, the decision making should be based on your history and examination, and not just the fact that the child has got a head injury or that they're intubated. You know, there was a child actually from one of the people involved in the panel who was from elsewhere in the UK, who had a child that had been brought in. She was 8, she was conscious, she was talking, but nobody listened to her. She'd allegedly been in a car accident. She was on the car and hard shoulder of the motorway, which was hit by a lorry. Her father was quite seriously injured. She had actually not been in the car. Her father had sensibly put her on the hard shoulder on the grass. She wasn't in the car. She was imaged from head to toe with CT in arterial and portal venous phases, completely unnecessarily. So the history and examination is really important here. Ultrasound can be helpful in follow-up, and occasionally our paediatric A&E doctors will persuade us to do an ultrasound. You know, if they're saying, well, we really don't think there's anything wrong with this child, he's going to be admitted anyway, can you just have a quick look? Then sometimes we might be swayed. But on the whole, CT is the way forward. Pelvic fractures are rare, again, because the pelvis in children is relatively squishy. So we don't do a screening pelvic X-ray in all cases, unlike in the adults where they get the chest X-ray, pelvic X-ray, and C-spine pretty much routinely. If there are pelvic fractures, they're often associated with multi-organ injury, and then again CT is the one that should be done. This child was hit by a bus and did have a pelvic X-ray because they were obviously very concerned about his pelvis clinically. There's a fracture through the sternum, there's a fracture through this SI joint, there are multiple fractures through the pubic rami. So this is a completely unstable pelvis, obviously hit with severe force. So the likelihood of underlying injury is going to be great. So he had a CT scan, and this is just a couple of slices. So this shows some unusual contrast collecting here, surrounded by soft tissue. And this is concerning for a bleeding vessel and hematoma, which indeed it was. So this is it here. And this is one of our only patients in our first 2 years of being a trauma centre who required interventional radiology. And he had that embolized and actually did make a really good recovery.
Can I just ask about a bit more about ultrasound? I've heard I remember with children with splenic lacerations would have follow-up bubble ultrasounds. Would you just be able to explain what that is?
Absolutely. So you can do contrast enhanced ultrasound in various settings. So it's quite commonly used in adults when you want to differentiate between certain focal liver lesions. It's very good at identifying hemangiomas in comparison to other like metastases and things. And at King's, they are really good at doing it in children. And if I was talking to you from King's, I'm sure I would have lots of lovely slides to show you of bubble ultrasound in various ways. Now, unfortunately, we don't use it. We keep thinking we might, and then because we have so few cases that would actually be relevant for, we haven't, like a couple of us have been on the course even, but we still aren't doing it. And basically uses micro bubbles, which basically create tiny little bits of air. So it looks bright and echogenic on ultrasound. And it's a really good way of looking at vessels. So I don't think they use it in the acute setting because obviously it's actually quite fiddly and you don't want to be doing anything that's going to delay any treatment at that, at that stage. But it is really, really useful in follow-up. And I think certainly at King's, they would use them for all their follow-up imaging, especially in spleen and liver, to look for the development of pseudoaneurysms or AV malformations post trauma. And it's also good for sort of showing areas of infarction. So I think it's really got a place, but it's not being used in that many centres at the moment. And I'm afraid to say we're not using it at the moment, although maybe we should be.
Thank you. Thanks a lot.
So interventional radiology is actually not used very much not needed very much in paediatrics, fortunately. Obviously, sadly, we do have a lot of teenage stabbings, and I'm not really including them in this talk because they are very much dealt with as adults in the general management of everything. As I say, we had 2 cases in 2 years that needed intervention. One was the child with the pelvic injury, and the other was a child who'd had a bladder catheter put in, and then the balloon broke off, and somebody had to go in and take it out interventionally. So not really kind of proper intervention, as it were. And it was pretty much the same across the country. So there was considered there wasn't really enough need to create a nationwide interventional paediatric trauma service. So as far as I know, and certainly in our trust, anything needed is dealt with by the adult interventional radiologists. If you're in outside a major trauma centre, you may need to transfer your patient in, and we do get patients transferred from elsewhere for an opinion. But as I say, even now, even with the stabbings and everything else, it's still actually very uncommonly needed, which is good, I guess. So for us, when we have a paediatric trauma call, actually I should put the trauma. This is the trauma team. So we're lucky because we have paediatric A&E. The trauma team leads may well not be paediatrically trained at the weekends, and that's one of the reasons why these guidelines have actually been really helpful, because some of them have no paediatric experience at all. And this is just a selection of other people that may or may not be attending a trauma call, depending on what type of history it is. But you'll notice at the bottom the radiology registrar. So our radiology registrars hold the trauma bleep, and will get notified as everyone else does on that team. If it's a code red, they will go down to A&E. If it's not, they will await in CT and await further instructions. From the point of view of what's happening in A&E, the child will have a primary survey and usually a chest X-ray, and then possibly a C-spinal pelvic X-ray, but that will be a matter of debate depending on what the history is. And then there'll be a discussion about what other imaging is needed, if any. So if you've decided that they do need imaging and you're going for CT, we will generally do what's called a combi scan. So this just means a combination of both arterial and portal venous enhancement. And this means one trip through the scanner, so it's one lot of radiation, but 2 contrast boluses, one with slightly delayed, so that by the time you're looking at the images, they've got contrast in both the artery and in the portal vein. If patients have a penetrating injury, they need a plain scan to start with. Like when I was talking about the CT heads, it's really helpful to see bright blood if it's collecting anywhere before you give any contrast. They then have an arterial scan, and then they have a portal venous scan, and they may even get a 4th scan afterwards if a delayed image to look at the renal collection system is needed, and that'll be done in about 10 to 15 minutes. So potentially they could end up with 4 lots of radiation. However, obviously they're under severe risk of leading to death, so it's considered well worth the radiation dose to have 4 scans instead of 1. This is the doses and flow rates that we give. So you'll see that the younger children have a slightly less dense version of contrast. And then the rest of the protocol is worked out on an age basis and with flow rates as well. Once they get over 15, they just get treated with the adult protocols. Once they've had their scan, the radiology registrar will fill in a checklist like this and give it to you to take away. And this is really just checking all the basic bits and pieces. So it's kind of like the ABC of radiology reporting. And it's just to make sure that they've commented on any major abnormalities that are present. What I would urge you to do once you've been given this is to then go take it away with your patient and go back to A&E and sort the patient out and wait for the report, rather than sit in the control room with the radiologist while they're trying to report, because it is thousands of images looking at in multiple planes. It's very, very difficult and stressful, and it's much easier to do it if you don't have somebody breathing down your neck or trying to make helpful comments. So they will then give you the report as quickly as possible. We have a few pathways. This is one for splenic trauma, and almost all the children end up in this section here, which is good in that they just get observed and eventually sent home without either intervention or surgery. This is, so what the question person was asking earlier about dual phase at 48 hours, probably at King's, they might well be doing contrast enhanced ultrasound in some of their patients at this point. Contrast enhanced ultrasound is good for the solid organs. It's no good for when you're looking at, you know, like an iliac artery injury or something, because you need the solid organ around it to see the contrast clearly. We will do ultrasound at this stage rather than CT almost always. So just a few images here, just to show you a few examples of different phases of contrast. So this child had been, this is one with a chest x-ray actually, so this was the contrast in the collecting system from the old scan. But if you look at the liver, it's quite hard to see any abnormality. When we repeat the scan with portal venous enhancement, we can clearly see there's a contusion here, which shows up much more easily on this phase than it does on the other, which is why we need to do the different sequences of contrast. We also have the delight of being able to use different reconstructions. So this is the coronal scan. So again, there's no further radiation to get these pictures. This is just using the data in a different way. So instead of showing it in one plane, we're showing it in another, but it's no additional dose of anything. And you can obviously see the blood vessels very nicely here. They are auto-bifurcating the IVC, contrasting the bladder. And this is the liver contusion. And this shows actually how it's very, very close to the liver hilum. And we don't get many of these injuries. We were particularly concerned about the potential for bile duct injury in this patient. So this patient actually ended up with a HIDA scan, which is a nuclear medicine scan that looks at bile excretion, to confirm that they had no bile leaking. But that this is a quite uncommon case for us anyway. There is free fluid. This is free fluid around the liver here, and free fluid in between the bowel loops down in the pelvis, which is just indicating that they've had some intra-abdominal bleeding. Then we move on. This is just showing the difference between arterial and portal venous again. So this was the arterial phase scan in another patient, and this is the hepatic artery branches that are enhancing. It does demonstrate some damage to the liver, but it's much more clearly seen on the portal venous phase. Now the portal vein's enhancing. You see the splenic vein here. So it just shows how you can see different things on the different sequences, and why we sometimes need to have each one done separately. So this girl then was admitted to the ward, and she got some abdominal swelling the next day. So they did this abdominal x-ray, which shows us really nicely that she's got a femoral line in and she's got a catheter in, but absolutely nothing else. The abdominal x-ray in this setting, unless you're looking for perforation, which we know she doesn't have because she didn't have it 2 days earlier, is absolutely hopeless, really. It doesn't show you how much fluid is in there. It doesn't show you anything about any organ injury or any progression of any abnormality within the liver or spleen or kidneys. I would urge that you not to bother with them, because really unhelpful. But they didn't take our advice and did another one the next day, which still doesn't show anything apart from the fact she's got a bit of lung contusion. No useful information about the abdomen. But now she's 48 hours post, so she goes for her 48 hours post CT, and in the lower slices you see actually there is lots and lots of free fluid, much more than previously. And then they do the test that would have been helpful 2 days earlier, which is the ultrasound. So this is all the fluid collecting within the pelvis. These echoes of blood, which is gradually kind of settling out and maturing into a hematoma. That's collapsed bladder, and this is a bit of fluid in the pouch of Douglas. So this ultrasound would have been much more useful if it had been done 2 days earlier, because this really shows us how much free fluid is in there. So the plain film is not useful in this follow-up setting, maybe in the acute setting of trauma, but not to look for fractures. But it gives you very little useful information about bowel or fluid or organs. So if you're not going to do a CT, then ultrasound is much, much more useful. We also went and looked, while we did that, doing that scan, we went and looked at the liver contusion, and now we can actually see it. So this is what the CT looked like on that day, and now we can see, it doesn't look the same on the ultrasound, but we can see the area of abnormality. So you've got areas of brightness, areas of fluid, a bit of a pleural effusion. So now we have something to follow up. And we could also see the vessels beautifully. This is the portal vein, looking nice and normal. These are hepatic veins, also looking nice and normal. So it's a really helpful examination. And now we can follow her up because we've got a baseline. This was a couple of weeks later, so the fluid component's got a bit bigger as the hematoma is resolving. The liver is looking a little bit more normal, and by 4 weeks, it's almost completely back to normal. So ultrasound can be very helpful in the follow-up setting, even though it's not that helpful acutely. And that's some references. So that is sort of the end of that bit. But if anybody's got any questions, I'll be happy to take any.
Can't see any questions, but that was really brilliant.
So I don't know how that can sort of, hopefully what I've said is the same thing as people who are talking about abdo trauma and head trauma. Hopefully we're all talking the same kind of sheet.
Yeah, no, that was absolutely brilliant. Thank you so much. And it's so good to see, especially like the other presentations and all the images. Thank you so much. Can everybody give feedback?
Yes, please. To everybody is obviously those guidelines are available on the college website, so you can download them and put them on your phone or whatever. And it's really just knowing that they're there, particularly the trauma ones. And I think certainly our trainees had a real problem with non-pediatrically trained trauma leads who wanted to go down the adult pathway and were insisting on, on really loads and loads of imaging when it wasn't appropriate, and not even knowing that the guidelines existed. So at least if you lot know that the guidelines are there, if anyone's asking your advice, at least you can point them in the right direction if they're being difficult and doing things that you think are inappropriate. But having put all this fear into you about doing CT, obviously it is a great examination, and you should not feel bad about irradiating children when it's the right time to do it, because it is a really informative, useful examination.
Brilliant, thank you so much. And I put the link for the feedback form in the chat box, so please fill it out, everyone. I'd love to be able to give you feedback. Thank you very much, Joanna.
Okay, thanks so much, Selena, and thanks everybody. Have a good afternoon. Bye.
Thank you.